Hi, hello, good evening. Since the exam time have started, most of the final year residents are having their practical exam in the upcoming November last week or in the December month. I got a couple of calls regarding the afternoon Viva and what are the stations, how the questions are. If you take the final DM exam, once you complete the major and minor case in the practicals, it is usually followed by Viva session. Almost always in most of the institute it occurs in the afternoon time. They usually divide it into 4 stations. First station is histopathology, where you will be given slides and you will be asked to identify the finding in the slides and you have to tell the diagnosis also. Second slide is related second station, and out of the 4 examiner, most of the institute like they might sit together or they might divide it as per the individual examiner. And the second station is of instruments. The instruments related like dialyzer, plasma versus the plasma filter, dialysis catheters, and whatever the instruments which are related to nephrology like peritoneal dialysis catheter, the previous one stiff catheters, soft catheter might be kept here. And third station is usually investigation related. Mostly it is the image investigation. Fourth station, it varies from institute to institute. Some institute keep the questions related to thesis. Some institute, the fourth station might be a grand viva where questions can come from any of the topic. Some places they keep the drugs, the important drugs like rituximab, cyclophosphamide, dose, complication, those things. And sometimes the question will be exclusively of dialysis, how to establish the dialysis center and all. So these are all the 4 Viva headings you have to handle. First is the station for histopathology, instruments, image investigation, and the fourth one, the place where I did my DM, we had this thesis plus the questions were related to dialysis. Since few of the juniors are having doubts, sir, what are the questions which can be asked in the respective stations? I thought of making it under 4 videos. So in this video, I will try to cover the image investigation or the station which handles the investigation related questions. So mostly the investigations are related to image. You might get a CT venography of AV fistula, obstructed central vein, or thrombosed IJV, or CT angiography might be there. In this video, I didn't keep any image. If anyone wants, let me know. I will try to cover individual CT or X-ray with the image and I will tell you what are the questions can be asked. In this video, I try to cover what are all the topics you have to cover so that it will be helpful in your afternoon Viva. CT venography, make sure you have seen the image before. AV fistula might be there. There might be dilated veins or CT angiography of any area, either probably it might be central vein or it might be of renal angiography. Usually you will get the image related to chest x-ray. Chest x-ray might be containing dialysis catheter. Even in this channel I have uploaded x-ray spotter series where I have uploaded few videos. X-ray might be having pulmonary edema, infection, post-transplant infection, nocardia, pneumocystis carinii pneumonia, CMV infection, even COVID. What are the differential, how to manage, these kind of questions are common. And dialysis catheter, if it is in the x-ray, you might be asked questions related to length, what is the proper position for the tip, what are the advantage of keeping the tip in the right atrium, what are the advantage of keeping it in SVC, disadvantage regarding the biofilm, permacath biofilm, what are the pathophysiology, and left side IJV permacath, what are the advantage, disadvantage, length, complication. These are all the questions you commonly encounter. And of course you should know the basics of chest x-ray, where the questions like whether it is PA view or AP view, how to say the X-ray is well positioned, adequate penetration or there or not. These are basics of MD level questions also you should be aware. Along with that, these kind of X-ray can be seen, a X-ray with the cavity, where they will ask you the differential of cavity in the post-transplant patient. Next, there might be image related to NCCT head. NCCT head, there might be presence of any space occupying lesion, especially in the post-transplant. The question definitely will go to post-transplant area, where what are all the finding in the NCCT CMV related disease, what are all the findings. It might be showing IC bleed. You might be asked what are the risk factor, resistant hypertension related questions. These are all the things you might encounter as a question if you get the NCCT head, which is unlikely because you will mostly get CT related or these kind of uroflowmetry related question. You should know the basics of uroflowmetry. What is Vmax, whether it is a screening test, what are all the things you can diagnose, what are the graphs you will get. So uroflowmetry is an important spotter in the afternoon. So please, before going for the final exam, make sure you are knowing this. Urodynamic study. Since the external examiners themselves nowadays they are bringing their own set of image and ask the students to answer those questions rather than using the investigation which are available in the institute. So be prepared for the urodynamic study graph also. Just have a look, ask your urology friend to send the report of urodynamic study, or during your residency course if you have seen a urodynamic study image, well and good. I am having an image, I will try to upload it in a video regarding uroflowmetry. I have already uploaded, you can see, and you should know what is the significant post void, when to say significant post void, and what are all the indications of uroflowmetry, what are the disadvantage of uroflowmetry. These are all the questions you might encounter. And kidney image is also very common, where you might be asked questions regarding Bosniak cyst. What are the classes, when to do procedure, when to do the surgery, and questions might go related to few, not in depth regarding renal cell carcinoma, but the basics. What are all the image finding to say it is a neoplastic etiology? And CT angiography, it might be showing renal artery stenosis, or there might be fibromuscular dysplasia. Look at the renal vessels. Whenever you get a CT, you should know how to read it, whether it is axial image, which section it is, whether it is contrast or non-contrast, because those are the MD level questions that you have to be very clear with. And how to read the CT, I will let you know once I show the images of the respective diagnosis. For example, I am having a CT angiography of renal artery stenosis that I will show. During that time I will tell you how to read those. I hope you are aware of how to say whether it is contrast CT or non-contrast CT. Here you might be asked questions related to difference. What are the DD of young hypertension? What are the management of renal artery stenosis? What is Goldblatt hypertension, Goldblatt phenomena, salt sensitive hypertension, and the FMD? What is the common age group? What is the management? Atheroembolic renal artery disease, age group, common. These are all the some common questions you might encounter once you get this. There might be MRI abdomen. Mostly it might be having ADP-CKD. The question will be how to measure the volume in ADP-CKD. ADP-CKD, they might go into the theory. Pro-PKD score might be asked. Chromosomes, cyst, extra, and other than that, probably you might be asked question regarding the contrast, MRI contrast, various types, GFR cutoff, and whenever you get a CCT also you might get ADP-CKD. The questions might be related to, they might be related to CT contrast also. What is the EGFR? What are the drugs which have to be avoided? And regarding ADP-CKD cutoff for like to say rapid progressors, and what are all the areas what are all the other than the kidney, where are all you will get the cyst? Those kind of simple questions might be there, but mostly the question will be revolving around pro PKD score and also this one kidney volume calculation. DTPS scan, definitely this is very high probability you might get the scan image. You should know the interpretation and what are all the indications of this. Mostly you will get DTPS scan, but you should know how the DMS scan appears also, because many a times they will give this image. Many students might mistake it because they might not have frequently seen this image DMS scan. So make sure you have seen the image. And DTPS scan question related might be regarding the isotope used, T-half, indication, how to identify a non-function kidney, post-transplant indication, and what are the findings, EGFR cutoff for the renal transplant. So these are all the questions you might encounter with respect to DTPS scan. DMS scan, probably indication you should be aware of and contraindication if they ask. Fundus image, there might be cotton wool spots, hypertensive retinopathy changes will be there, CMV retinopathy, that tomato ketchup appearance. Few examiner might want to know whether you have seen fundus or not before, and most likely they will come up with simple finding only, like papilledema, diabetes, hypertension. They might come up with image or they might show you the PPT to identify that. So that is why make sure you have seen the fundus image, especially of diabetes, hypertension, and also papilledema. Since these are very common, the examiner expects the final year student to be thorough with the finding. The question related to it might be regarding the stages of diabetic retinopathy, hypertensive retinopathy findings, and post-transplant patient CMV. Less likely, even if you are not answering this question, there is no harm, but you should be aware of diabetes, hypertension, and papilledema, how to diagnose. Renal artery Doppler might be there. The questions might be related to like what are all the finding resistive index in renal artery stenosis. Again, gallbladder hypertension, renal artery to aorta ratio you should be aware of. Make sure at least you have seen one report of renal artery Doppler before going to the final exam, so that you will know the parameters, what are the things to be seen to say it as significant renal artery stenosis. Some rare scan report you might encounter, like parathyroid scan, because secondary hyperparathyroidism, what is the investigation? System scan. And for bone fractures, bone scan, since multiple myeloma cases, if they are having, probably you might get a X-ray skull also, X-ray skull or any fracture which was related to the secondary hyperparathyroidism. So you should be aware of system scan, and just look at the image of bone scan. At least during your residency, if you didn't see, just Google it and see how the bone scan appears. PET scan might be there, RCC, to because mostly a post-transplant patient are more prone for malignancy. The question might be related to post-transplant malignancy, post-transplant lymphoma, FDG, fluorodeoxyglucose mechanism, how it is being done. Probably you might encounter, which is very rare, but these images can also be asked. Next, the most important one are CT angiographies, definitely DTPS scan, and the most important is intravenous pyelography. You should know in and out about this, how to do it, which investigation have surpassed this, why it is not being used commonly now, what are the indication, what are the diagnosis you can make up with this, you have to be aware of. For IVP, I will come up with a separate video because it itself, the question and answer related to this might take 5 to 10 minutes. So make sure you are aware of IVP, all the finding related to it, because normal and abnormal very difficult to predict. Suppose if someone is not exposed to this image during the residency times, so make sure you get few images from urologist also and ask how a normal image appears at what point of time the image is being taken. And another next important investigation image you might get is voiding cystourethrogram. The question might be related to indication, what are the conditions you can diagnose, how to give the contrast. If the examiner want to check whether you have the real-time clinical exposure or not, if they ask how to give contrast, many students, if they didn't see, they might not able to tell. So that is why it is very important you should know these answers, how to give, what is the contrast being used, what are the contraindication, what are the condition it can diagnose. Retrograde urethrogram image you might get. Regarding VCUG and retrograde urethrogram, I have uploaded the images. You can see either in the community tab or in the shorts, or in the subsequent PPT I will upload whichever images I am having. So simply you might get ECG. ECG you should be thorough with electrolyte abnormalities, pericardial effusion. There will be low voltage complex, and you have to brush up your MD ECG theory knowledge, like how to say low voltage complex, less than 10 small boxes in chest leads, less than 5 small boxes in lymph nodes, almost all. And there, what are all the ECG finding in pericardial effusion? Like you might be asked regarding the big stride, cardiac tamponade related question. Hyperkalemia, most likely they won't keep because that forms a very simple level of question. You might be getting ECG related to hypocalcemia. And you might be asked questions regarding AVF Doppler. What are the parameters you will see? What are the changes after making AV fistula? You might be asked, little bit rare. You might get a fistulogram image. This is also bit rare. Mostly CT venography of the fistula are more common than the AVF fistulogram images. Make sure you have seen the inflow vein, outflow vein. The question might be related to the parts of fistula and the rule of 6. What are the long-term complications? Steele syndrome. These are all the questions you might be asked. Probably questions related to AV graft, hero graft. What is hero graft? These kind of questions you can expect. If examiner interested, they might ask questions related to contrast USG. Just make sure you are aware of this recent update on the USG, like contrast USG. And definitely there will be a image you might encounter related to X-ray QUB. There might be presence of digestin, presence of PCNL. Question might be related to radio opaque stone, radiolucent stone. Stachan calculi might be there. You have to be very sure Stachan calculi whether it is seen in IVP or in the simple X-ray QUB. These images are very important. There's a high probability you will get X-ray QUB with digestin, PCNL and stones. If PCNL, they might ask you the indication. Digestin, they might ask you the duration of digestin, indication, when to remove it. And other than that, probably they might ask you what is the price if they want you assess as a whole whether you are having the knowledge of this price and all. So they might ask you these questions. You might get an image of retrograde pilogram. Mostly questions related to VUR you might get indication. Whenever the questions of VUR comes, there will be definitely question regarding stages of VUR, management, pyeloplasty when to consider. These kind of questions you might get. HRCT chest images is also common, where you might get a cavity. After the COVID time, you might questions related to COVID. nocardia, pneumocystis carni pneumonia, HRCT, whenever it is there, definitely the question will go to post-transplant area. Most likely they will ask you to diagnose the condition based on the image. So always look at the CT findings of nocardia, CMV, PCP, and how to diagnose the cavity, which cavity it is, whether it is tubercular or abscess, fungal ball. Question might go to aspergillus related thing also. So make sure you brush up this theory knowledge. MRI brain, probably there might be any space occupying lesion, lymphoma. If they are giving any angiography or MR angio, probably the question might be related to the CNS aneurysm, which you commonly seen in ADPCKD. So this MRI brain is also a little bit rare. If it is there, it might be related to the space occupying lesions. Next, most important, NCCT KUV. So again, I am telling you should know how to read the CT, how to say whether it is contrast or non-contrast. Then the NCCT might be showing bilateral hydronephrosis, probably unilateral. Question might be related to the etiology of hydronephrosis, renal stones, ureter stone management, and the renal masses you might get where it can be seen in NCCT or CECT. Definitely questions, as I told before, Bosniak cyst you should be aware. Renal angiomyolipoma you should be aware. Tuberous sclerosis, few questions goes there. So I hope I covered all the possible investigation station related questions. Will you get all? No, one or two images you will get, but these are all the possible images you might get, even if the examiner brings their own set of images. And in this video I hopefully covered all the investigation related questions, and whoever appearing for the exam, if you got the question within this video, well and good. If you get any questions out of this video, you can come and put it in the comment section. I hope it will be helpful for you for your upcoming exam. All the best. In the next video I will come up with histopathology related Viva questions. So thank you. Good night.